Okay, guys. Today we're talking about schizophrenia. Now, schizophrenia, no diagnosis just absolutely terrifies families like the diagnosis of schizophrenia. The reason for that is there's a lot of misunderstandings. There's problems with variety of social functioning. And schizophrenia is a diagnosis where somebody has paranoid delusions. They these could be different types of delusions. Could be delusions of grandeur. I'm the president. Marine One is coming to pick me up from the hospital, or you can't treat me that way. That um, it's very important that you know that I'm the president or the king or I have special powers. Dakota, you here now?
Yes, sorry, I
Uh,
was trying to get logged on.
no worries. Okay, I'll get you corrected afterwards. So, with schizophrenia, there's going to be some thought confusion. There's going to be some changes in the way people are thinking, and it often people will be afraid of schizophrenics becoming violent. In all honesty, the bigger issue is people with schizophrenia becoming victims of crime, not becoming the actual perpetrators of a crime. And so, with that, within our general American society, we don't really think of it like that. We think of people with schizophrenia that they're scary and that they're out to get us, when in reality, they are just trying to do their own thing and live their own life. Now, with that said, hallucinations are common with schizophrenia. And with these hallucinations, by far the most common type of hallucination is auditory hallucinations. And so, with these auditory hallucinations, they're not saying nice things to these people. They're not saying, you got this test. You studied, you have good self-esteem, you are a good person. That's not what they're saying. It's constant over and over bombardment with negative messages. You're stupid, you're an idiot. Why would you ever be able to be a nurse? Um, you're going to fail this test just like you failed all the others because you're worthless. So it's a lot of negative hallucinations that you'll see. And you also may see visual hallucinations as well. Now, tactile hallucinations, feeling like bugs are crawling on you, can also be a part of it when there's nothing there. But by far the most common tends to be auditory hallucinations. And that's something that most of us don't have, is this voice. It's like a tape running in your head. You're stupid, you're ugly, you're fat, you're worthless. And everything is just negative that it says. And what happens, think about if you heard that all the time. Would you be agitated? Yeah, most of us would be. So with schizophrenia, your patient is going to have some bizarre thoughts, bizarre perceptions, may have some bizarre movements. So we talked about last class the waxy flexibility, where if you move their arm up, it will stay in that position until you, as the clinician, move that arm back down. That is a form of catatonia. Okay. Catatonia is where you will just kind of freeze in various postures. And so with this, they tend to have very distorted and bizarre thoughts, movements. And there's two general categories of symptoms. So there's symptoms that are in addition to, that most people don't have. So for example of these positive symptoms. Now this doesn't mean positive and negative as in good and bad. What this means is positive in addition to normal cognition, normal thought, normal behaviors. Okay. So Positive means in addition to. So with this, they're going to be having delusions. They're going to be having hallucinations. They may also have negative symptoms. These negative symptoms are taken away from their normal thinking, normal thought, okay, their normal level of affect. It's something being removed from what most people have normally. So, most people, you can look at their face and it is a reflection of what they're feeling. With schizophrenics, they look the same: happy, sad, angry. They show no facial affect. Okay. They tend to be very inattentive. Could you pay attention during a lecture if you have these voices going on in your head talking about what an idiot you are? So, with this, it comes off as they're inattentive when in actuality, it's because they're having other symptoms that you probably aren't aware of. So you may often see schizophrenics, they'll be off to themselves and just kind of, they may try and respond to the voices and talk. And so it'll appear that they're talking to themselves, or they will just kind of zone out. And as a result of that, they're listening to what's going on in their head. Positive symptoms are easier for us to get rid of. Okay. We can control the delusions. We can control the hallucinations with first and second generation antipsychotics. Now, the positive symptoms are caused by excess dopamine. Now, we know that we can actually medically induce a schizophrenia like state because there's another medical condition, Parkinson's disease, that a person has problems with movement and it's due to a lack of dopamine. So as a result of them having a lack of, of dopamine, hold on just 1 minute. Okay, sorry about that, guys. Okay, so positive symptoms are going to be um, things that are a result of too much dopamine. Okay. And so we thought that because Parkinson's disease, L-DOPA, we would give them the L-DOPA, and if they get to a certain dose, too much dopamine within their brain, they develop the signs of schizophrenia. So it was thought that early on that schizophrenia was simply the presence of too much dopamine within the person's brain. But as we've done more research on schizophrenia, what we have found is that the positive, that in addition to symptoms of delusions and hallucinations, that these are the result of too much dopamine. So we can get rid of those symptoms. They're easier to treat. The negative symptoms are more difficult to treat. And often, when we treat the positive symptoms, the negative symptoms can get worse. And the reason for that is it's too much dopamine in certain parts of the brain, and other parts of the brain are being starved from dopamine. Those parts of the brain that are being starved from dopamine, these are going to be your negative symptom areas. This is going to be flattened affect, lack of volition, inattention. So, with this, the positive symptoms, we can suppress and we can block the dopamine. But we can't just block the dopamine in certain areas of the brain. If we block dopamine, we're blocking it everywhere. And so, treating the positive symptoms can make the negative symptoms worse or make them harder to treat. So, schizophrenia is usually diagnosed during late adolescence or early adulthood. They have done twin studies with schizophrenia. And what this means is twins have the same genetic material. and there is a genetic propensity, genetic connection to schizophrenia. So it usually is diagnosed in late adolescence or early adulthood. And the reason for that is the brain is still continuing to develop. And as a result of the brain continuing to develop, as the frontal lobe is maturing, that's when you're going to see the problems, such as schizophrenia, that happen. So it's thought to be about 1% of the population. Often there will be a first degree relative that has schizophrenia. And with this, you also see twin studies where if one twin has schizophrenia, it is significantly more likely that the other twin um, will become schizophrenic as well. So schizophrenia is on a spectrum. So what we've talked about so far is the full on person with schizophrenia. Okay. They have thought abnormalities. They have emotional regulation problems. They have flattened affect. They may have movement disorders. Now, schizoaffective disorder, schizophrenia is on a continuum. Schizoaffective disorder can is often considered to be a mixture of mood symptoms such as depression and a mixture of psychosis and psychotic symptoms. The client is severely ill, regardless, and as a result of that, they often will get involved with the medical system because of you hear things, you say you're hearing voices or people are talking to you that nobody else can hear. That tends to be a red flag for most of the population to seek help. So your onset is different. This is similar to other mental health disorders. You can have the genetic components for it. It does not mean you will develop the disease. Something has to happen to those genes to activate the genes or turn them on that contributes to the development of the disease.
Could that be like a traumatic event or something like that?
I'm sorry, I couldn't hear you.
Could that be like some type of traumatic event or
It isn't likely to be a traumatic event that activates it. They really don't know 100% what activates it. One thing they found is that people who are diagnosed with schizophrenia their mom tends to be pregnant with them during flu season. Now, with that, that's confounding because if we look at birth rates, we have a ton of people born in September. And so, as a result of that, most people who are born are actually, um, they're more likely to be born in September, being conceived in December, January. So, we really don't 100% know. Research is still ongoing for that. So what we can see is that they get up one day and bam, they have the symptoms. They have the psychosis, they have the thought abnormalities. And with that, if we get involved early, um, if we get if we start looking at that early within the symptoms, we often can help them make a complete recovery. However, the more their brain is functioning in such an erratic way, the more difficult it is to actually get rid of the symptoms and treat it.
would that be due to like the brain kind of rewiring how it processes things?
I don't have anything. Sorry about that. Okay, so schizophrenia happens over a long-term course. The and with what happens is over time, the psychosis becomes less And so they're able to control the symptoms. The disease becomes less disruptive. So if we can give the people the psychiatric support that they need early in their life, then they may be able to function independently later in life. However, if you have something going on in your brain where you are being told constantly that you're stupid, worthless, etc., it often affects your interpersonal communication abilities um, over the long term. So, with schizophrenia, you'll see a lot of people will be living in a group home situation with schizophrenia. You'll also see a lot of comorbid conditions with schizophrenia. Schizophrenics, along with all straight across the board mental health diagnoses, people tend to smoke as a way to help fix the neurotransmitter deficiencies within the brain. However, smoking also alters the medications, and it alters the metabolism of the medications, and it alters the ability um, to treat the actual mental health conditions. So, as I said, schizophrenia is on a continuum, right? So, we have full on schizophrenia. We can have patients who are catatonic, that's where they freeze and they have the movement abnormalities. We can have somebody that has a delusional disorder, that they have paranoidal delusions about other people, or delusions of grandeur, or delusions of reference. Grandeur is I'm somebody special. Delusions of reference, that TV reporter was talking to me. So the person on TV is directly putting thoughts into my head. This could also be that stars, like movie stars, are putting ideas in people's heads. And so that's a delusional disorder. Now, it's called delusional disorder if they're not having the whole other gamut of symptoms. It's just primarily the delusions that are problematic. A brief psychotic disorder is when they hear voices, they have a break with reality, but we are able to get it stabilized and get it to go away with either first generation typical antipsychotics or second generation atypical antipsychotics. So genetic factors, we've talked about that. We've talked about that there's differences within the amount of neurotransmitters in the brain, and that dopamine is a key player. Too much dopamine in certain areas of the brain cause what kind of symptoms?
Positive.
Positive. Not enough dopamine in certain parts of the brain cause
Negative.
negative symptoms. So we think that there's some kind of association with viral exposures. With that said, we really don't know because that research is confounding. Okay, good question, Robert. Shared psychiatric disorder. This is when, shared psychotic disorder. This is when one person is the mentally ill person. The second person that is in this shared delusion are so close to that person that's mentally ill that they too become ill and they start to develop a shared delusion. Okay, and
Is
it can
that
cause.
like Munchausen's or
Say that
similar
again.
to, I don't know the right. Is it like Munchausen's or like the disorders like that?
Not exactly. Munchausen's is something's being done for personal gain. We'll watch a video. If we can't get to it today, we'll get to it next week, about shared disorders. So there's a really interesting case of the Erickson sisters, and this happened. They actually are from Sweden, but they happened to be in Great Britain, and they ended up, their delusion was so strong that the authorities were after them for whatever reason. They could never very clearly communicate why the authorities were after them. but they became so frantic on getting away from the authorities that they started running all across the interstates. And there happens to be a video crew that was with some officers that caught all this on tape. So we'll watch a video about that. But shared delusion disorder is different than Munchausen. Munchausen, I am doing something to physically make another person ill. Shared psychotic disorder is one person is going to be the one that's truly mentally ill, and the second person is more of a follower. And as a result of that, ends up buying into the mental illness as well.
She's had on the sheet as well,
Okay.
but it doesn't go wet.
So with this, we also have to take things within a cultural context, blankets. And what this means is that within the cultural context, that we have to take into consideration the person's culture that is mentally ill. And so with this, in some cultures, let's say Native American cultures, it is quote unquote normal to have hallucinations when you're doing certain ceremonies, or if you're using ayahuasca or something like that. So that is a cultural bound syndrome. And there's also ethnic differences in response to psychotropic medications. Um, One key example of this is that people with red hair and blue eyes tend to be very pale. They also tend to metabolize psychotropic medications at a faster rate than other populations. And we're really not sure why. We know it has something to do with the cytochromes within the liver and how fast the metabolism is happening, but they require higher doses of medication to control the illness than other persons. Okay, so psychotherapy treatment, we treat this with conventional antipsychotics. Okay, this is going to be typical antipsychotics. And with this, we're going to be targeting the positive symptoms, because remember, these are dopamine antagonists. Okay, so we're not going to be able to do anything with the negative signs, negative symptoms. It may actually make it a little worse because we're blocking dopamine everywhere in the brain. We're not just blocking dopamine in that specific area where the positive symptoms are occurring. So with the conventional antipsychotics, we see a lot more side effects related to this, like tardive dyskinesia. Tardive dyskinesia is where it looks like people are done are doing things like that. Okay, it's going to be looks like they're chewing on their tongue, or their tongue will just randomly stick out, or they don't actually close their mouth all the way because their tongue is sticking out. Okay, so that's tardive dyskinesia. Now, this is one type of extrapyramidal symptom. Okay, EPS can be a lot of different things. Okay, extrapyramidal symptoms. They can be tardive dyskinesia, the tongue stuff. They can be different types of tremors. It can be akathisia. Akathisia is where it's like you have a motor in you. And so you keep going and keep going and you keep moving and you cannot stop. Okay. It has activated something within your brain and it's making you go, 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 go. So with this, we tend to prefer atypical antipsychotics today because the side effect profile is better. Meaning they're less likely to develop extrapyramidal symptoms. They're less likely to develop neuroleptic malignant syndrome. And we'll talk more about that in a minute. Okay, so atypical antipsychotics, because they work on dopamine and serotonin. Now, you got to remember, there are more serotonin receptors in your stomach than there are in your brain. Okay, that's the reason you get anxious, you automatically get a tummy ache, and it has to do with the serotonin. Okay, so with atypical antipsychotics, one of the big side effects you have to watch out for is weight gain. And so most of the atypical antipsychotics, except for about three, um, actually have increased weight gain as part of it. But because it's also working on serotonin, it also will help to improve negative symptoms as well as positive symptoms. Now, one thing we have problems with within the mental health field is that people feel weird. They have been used to hearing voices for years. And then all of a sudden, we give them medicines and it stops their racing thoughts and their thoughts move slower and it decreases their paranoia and they're having less of the voices. And so they feel like it's making them weird. And schizophrenia, it can be, oh, you're controlling my mind. Well, and it can increase the paranoia. So, what do? They stop taking their meds. You stop taking your meds. So, what happens? You get sick again, right? Okay, so we have several antipsychotics that are available as depot injections. So, talked about during boot camp these decanate injections. So, two of them, fluphenazine and haloperidol, are both available as a decanate injection. Now, a depot injection is the exact same thing. Okay. A depot injection means I don't have to take pills every day. The medicine is absorbed in a solvent that's going to dissipate the medicine as it can. Okay. And so with that, like one of the shortest is aripiprazole. It has to be given every 2 weeks. Okay. Others can be given every 6 weeks, every 8 weeks. I am not going to ask you which medication has to be given over what time period, okay? Or like re-given the next dose. But what I want you to know is these medicines have depot injections. Depot injections mean you don't take a pill every day and you have long-term medication in the body. So if you, let's say, have a patient who is medically required to take treatment or ordered through the court ordered for treatment, can we make sure they take their pill every day? No. Can I make sure that they're in my office every 6 weeks to take their medicine? That's going to be a whole lot easier to do once every 6 weeks than fighting with them every day over it. Now, you do still have to use oral therapy initially to get the patient stabilized before you can transition to these depot injections. And that's just to make sure you're getting the right dose for the patient. So we talked about that there's side effects, and on your medication sheet, this is the kind of thing I want you to know, okay? So I want you to know atypicals tend to have weight gain as a side effect, okay? There are three that have less weight gain. I'm not going to ask you specifically which ones those are. That's at a whole different level than what we're looking at. I'm not going to ask you drug doses. Okay. What I want you to know is if a patient is on haloperidol and they are having symptoms of they feel like they have to move all the time. Okay. Or they're having dystonic reactions. This is going to be like their neck is twisting back and it appears very uncomfortable. Okay. That's called torticollosis. That is a side effect from this medication. And usually, if somebody can't move their head and it's trying to look back, that's quite painful. So they're going to seek help. And that is a form of a dystonic reaction. Parkinsonianism is going to be we have blocked too much dopamine, so our patients get the pure pill rolling tremor and the shuffling gait with the feet. And it's called Parkinsonianism because it's not Parkinson's disease. Their brain makes the dopamine, we have blocked too much of it. So that's the difference in Parkinson's disease and Parkinsonianism. Tardive dyskinesia, that's going to be the tongue thing, chewing the mouth, facial movements. You may have persistent twitches of a certain side of the face, and that can be a result of tardive dyskinesia as well. Some of these medicines actually lower the seizure threshold. They make it more likely, they increase the rate of having seizures. Now, neuroleptic malignant syndrome. There's going to be two of these that you have to differentiate, okay? One is going to be serotonin syndrome. Serotonin syndrome is going to happen from antidepressants. Let's say a patient accidentally gets prescribed 2 SSRIs, okay? And so that causes too much serotonin. That's going to be serotonin syndrome. Neuroleptic malignant syndrome is going to be a result of antipsychotics, okay? So in the question, you will be able to discern what type of condition we're going for based upon the medications that the person's on. So if they're on 2 SSRIs, serotonin syndrome. If they're on an SNRI, serotonin syndrome, okay? If they're on risperidone, neuroleptic malignant syndrome. If they're on Halidol, neuroleptic malignant syndrome. And the reason those two are confusing is they have a lot of similar symptoms, and we'll be talking more about those later. So, other major side effects, I told you weight gain. Sedation can be a side effect. When you are so agitated and so paranoid, sleep is going to be a problem. So, sedation can be a good thing for patients with these conditions. Photosensitivity. So this is going to be sensitivity to sunlight. So they're more likely to burn. So with that, what would you need to tell them as a nurse?
Sunblock.
Sunblock. Make sure you wear sunblock, big hats, if you are going to be out in the sun for any period of time. Also, anticholinergic symptoms. Okay, these are going to be a big thing with people who are taking antipsychotics. So, dry mouth, blurred vision, constipation, slows the poop, slows the pee, and so orthostatic hypotension. So, with schizophrenia, big thing is we do individual therapy, we do group therapy. One of the key factors is family therapy because mental illness doesn't occur in a vacuum. Mental illness requires that people have understanding, know what to predict, know what to do when behavior is unpredictable. What can they do to help make it more predictable? How can they adapt? How can they help their loved one create social skills? So the loved one isn't sitting there by themselves in the middle of a restaurant having a full-on conversation with the voices in their head. Help them understand that that weirds people out and that that is not a way to fit in within society. Okay, so with schizophrenia, suicide is a big risk. Okay, so the earlier that the person has symptoms of schizophrenia, the worse the outcome. Okay. Again, the longer that the brain is struggling, the more difficult it is to treat. Looking at the person's current support systems, do they have family that are trying to understand? Or has the family just literally told them you can't act normal, get out of the house? A lot of our homeless population are actually schizophrenics, who are unmedicated. And then we talked last time about they were literally just kicked out of mental institutions back in the late 80s. So they may appear weird, okay? They may appear odd. They may move very slow, respond very slow. And they have something called word salad. This is where word salad is. I'm saying a whole bunch of different words, but none of them make sense together. I'm not communicating clearly. I'm not sharing my thoughts clearly. Echolalia, this is where I repeat something the clinician has said or something that they have heard. Like, they'll hear something on TV and then just start repeating this phrase over and over. Now, their responsiveness, you ask them questions, they tend to be just moving very slow. Their brain is functioning very slow. They're unlikely to have any kind of affect on their face. It's often very flattened. And now blunted is you can still see most of the time they're flat and you can't see anything, but occasionally you see some other emotion come on their face. That's blunted affect. Flat is you don't see anything, any type of emotion whatsoever. Anhedonia, they don't enjoy things. So, but think about this. If you were trying to do something that's fun and you're hearing these awful voices all the time, could you have fun? Probably not. So, thought process tends to be very slowed. They frequently will think that somebody else is blocking their thoughts. Like, instead of they just forgot something, someone is removing thoughts. They're not allowing me to think about that. Thought broadcasting. Other people can read my thoughts. Okay. Thought withdrawal. Instead of just blocking it, they're taking away the whole thoughts, the whole ability to think. Thought insertion. Another person is physically inserting thoughts in my head. So delusions, we've talked about hallucinations, that they can be any type of hallucination. Most common, auditory, visual, and tactile. And they often will complain about feeling like they are watching themselves. Depersonalization. They are a character in somebody else's story. They have impaired judgment and they have impaired insight. They think that they are above, better, and that other people are doing things to them. They tend to lose ego boundaries. So they lose where they stop and where another person begins. Okay. Frequently, schizophrenics, they're behaving weird. People aren't going to want to hang around them. They are very frustrating in family and community relationships because their thoughts are so slow. They're so unpredictable. And that's due to everything going on within their head. Okay. So they often will lose lose caring about any kind of hygiene or grooming. Okay. They will start to ignore different bodily sensations. Okay. So with that, they may be peeing on themselves, pooping on themselves. Polydipsia, they tend to be very thirsty. You often will see diabetes in comorbid with schizophrenia because their impulse control is so weak. So with that, they will decide that they want candy. And if they have access to the resources, they will eat the entire bag of candy instead of just a piece. Yes, people can be functional schizophrenics. We really don't call them that. We would say that they are coping better within the community. And there are different labels for different people on different places in the schizophrenia spectrum. So in your book, there's a table that outlines like brief psychotic disorder. So for 2 weeks, they had psychosis. Bam, we gave them antipsychotics, we got them fixed. They're no longer having psychosis. Okay. In contrast, to even be diagnosed with schizophrenia, you have to have the whole conglomeration of symptoms. Yes, Beautiful Mind is very clear about schizophrenia too. But with that, you have to have the whole conglomeration of symptoms for over 6 months. So this is not a diagnosis that is just going to be slapped on somebody willy-nilly. They have to have consistency in poor functioning, poor thought, poor coping for a long period of time. So, as I've said, um, you want to make sure that you are taking care of yourself, making sure not to invade certain bubbles around people because there is a risk for violence, but you want to protect yourself first and foremost. The bigger risk is actually for suicide. A lot of people with schizophrenia commit suicide. Um, and as we talked about, there's differences in the rates of completion for suicide for men and for women. Women tend to do things like take pills that you have the ability to intervene in and before it becomes a permanent, before the person actually dies. Whereas guys tend to do things that tend to be more disfiguring, like hanging or gun violence. They'll have very impaired verbal communications, and they may have disordered thinking or delusional thinking. So, outcomes, we want to make sure that we focus on client safety. We also want to talk to other people who are in this person's normal day to day environment. So, we also need to teach them how to communicate and how to express feelings in a safe manner, socially acceptable manner. And so teach people how to talk, okay? And part of that we've already talked about, I statements, etc. And then adhere to interventions. Early on, the person with schizophrenia will have to be hospitalized to be stabilized, okay? If the break is bad enough, if their behaviors are bad enough, if they are thinking of hurting themselves or another person. Once we get them stabilized on medication, and if we are able to have them develop insight into their illness, for them to understand that hearing voices is not normal, that this is something that their brain is doing, teach them ways to ignore those voices, then we can help them to be functional members of society. Okay, so part of this is going to be helping them or their caretaker do self-care, making sure they're eating, making sure they're sleeping, helping them to develop social skills, medication management. We may have to have, and if you work in community mental health nursing, you may actually be going out and setting up patients' little pill boxes and then making sure the other medications are locked up. So it makes it more difficult for them to overdose since they would just have a week's worth of medication at a time. And then we want to consistently evaluate what is going on with the patient and ensure that we are responding with wraparound community resources that they need to better manage their disease. So we've talked about before that you never confront a client's delusions. If we say that's not real, makes it more steadfast that yes, oh yes, it is. And so with that, when they're talking about it, you never want to feed into it. You just kind of say, oh, okay, and then just kind of drop it. So typical onset, the earlier the onset, the worse, more severe the condition is. Typical onset is when the prefrontal lobe is developing, so late teens, early 20s. Most people will not be diagnosed with schizophrenia after the age of 45. And with that said, I'd be willing to even go lower than that. So, psychotic symptoms that happen in later life are usually associated with psychosis associated with dementia or depression, not actual schizophrenia. And we'll talk about those later on. So, long-term outcomes for people with schizophrenia, they've had their disease for a longer period of time, so they're better at coping with the voices, coping with the symptoms of it. As a result of their improvement in coping strategies, this they have a decrease in positive symptoms. So remember, those are the ones that are too much. They're in addition to normal behavior, right? About 1/4 go from schizophrenia into dementia, and this causes a further decline in health. As a result of going from one mental health condition into another mental health condition. The remainder of people with schizophrenia, the disease remains stable in about 50% throughout life. So we have to have wraparound community-based resources. It is often very difficult for a person with schizophrenia to be able to take care of themselves. They need to have somebody to cue them on hygiene, cue them on taking medications, be around to watch as symptomatology increases so they know if the medical providers need to be notified. Behavioral health care, counseling helps, case management services. You'll see this a lot within Peninsula. You'll see case management is very involved with patient management and ensuring that they can access the resources. Helen Ross McNabb also does a lot of this in Knox County, and they are both community-based mental health programs.
Are they allowed to live alone after they've been diagnosed?
Say that again. The words were breaking up at the first part.
Are you good? Are you allowed to live alone after you're diagnosed?
If you are functionally able to, absolutely. Okay. However, most people with schizophrenia will have difficulty living alone. Now, if you have appropriate case management and wraparound community services, then yes, you are more likely to be able to live alone and be successful. You can even maintain a job with schizophrenia. Often, the types of jobs that people will have when they have schizophrenia are going to be jobs where they tend to work off by themselves and really don't have much interaction with others. So our goal is, this is still a person. It's a person with schizophrenia. We need to help them to figure out how to manage their own life, how to make decisions, okay? They need to be involved in their treatment. Should I hide a diagnosis from a patient?
No.
No. Never, ever hide a diagnosis from a patient. By letting them know what is going on and why it's going on, it helps them to be able to cope and helps them to improve their insight and to their mental illness, and to be able to function better um, at managing their life, making their own decisions. Now, if I say you will take this medicine, what tends to happen?
They'll say no.
They'll say no. Then you have a power struggle on your hands. And so, with that, you've got to educate them about what the medicine does, how it helps, um, so they know what to expect. They know they may feel strange. They may want to stop taking the medication, but they can't. Prodromal signs. People who work with schizophrenics will often say that you can tell when they're about to get worse, okay? That their behavior starts to become more erratic, their thinking starts to slow. And again, the earlier we recognize the signs of schizophrenia and we can identify those who are at risk of developing schizophrenia, we can get them on the medications and help them to keep their brain out of that state where actual damage is happening. So, big things to be aware of is that not to take offense. If they think that you're poisoning them and you're giving them toxins in their medicines or you're messing with their mind, don't take it personally. This isn't about you. This is about the client's behavior. If it wasn't you giving those medicines, it would be somebody else who they would be thinking this about. So this is not a personal attack on your character. This is not a personal attack on you as a person. This is a well-known part of the illness. Now, when the first time that you see people coming down off substances, um, tweaking, as we call it in society, it kind of freaks you out. The first time you see people who have different types of mental illnesses, it freaks you out. And it's absolutely normal for it to. The key is to protect yourself with everybody. The depressed patient, the ADHD patient, okay? You have to take care of yourself. The hospital is not going to take care of your family. They're not going to take care of you. You have to take care of yourself, okay? So, with this, the things to be aware of is knowing things are heading south and what you need to do. Again, don't let the client block you in a room, okay? You sit them closer to the window where you are closer to the door so you can get out, okay? Focus on the time that the person is stable, that they are able to be out of a hospitalization context. And so you also want to see people as they are getting better. We can have a lot of care fatigue, compassion fatigue as nurses, especially if we are only seeing people at their absolute worst. So it helps us to be able to recognize that, I haven't seen so and so for 6 months. That's a good thing. He was in here every 2 months. That tends to mean that they're more stable, okay, for you not to see them. Okay, what questions do you have for me?
Dr. Stanley, with regard to that shared psychosis, so the family member or the loved one who is sharing in the delusion of the mentally ill patient, do I mean are they getting treatment as well? Is there
That's the
or
only way to break it
yeah,
is for both people to get treatment. It
okay.
is unlikely that the core mentally ill person, will break the delusion. Okay. However, the person who has bought into the delusion, the one that is healthier mentally,
Yeah.
then yes, absolutely. Therapy, medications to help break the delusion. Since you guys are interested in that, let's see.
Oh, and earlier it was hypochondriac I was thinking about.
Online courses
Okay, hypochondriac instead of Munchausen.
offered by Purdue
Munchausen
Global
is
helped me to grow in my career as well as it helped me
literally
to learn new
you are
management skills.
making somebody else sick on purpose. Okay. And so I'm giving them poison, or I'm giving them medications, or I'm tainting their food to make them sick on purpose. A hypochondriac, on the other hand, is severe anxiety about any potential symptomatology. Does that make sense? So this is
Yeah.
actually a delusion instead of that. It is a false and erroneous belief. Make sense?
Yes, that makes sense.
Okay. Often, yes, it can be in enmeshed situations, this shared delusion. So I'm going to play this, and somebody needs to let me know if you can hear it. Sometimes sound is wonky.
A doctor, she has been knocked down.
Is she the one that speaks English or the other one?
Can you hear it?
She's the one on the
Okay.
The M6 is the longest motorway in the United Kingdom, stretching 230 miles from the Midlands all the way up to Scotland. On May 17th, 2008, however, highway CCTV picks up footage of two women walking down it. Where are they going? Why are they on foot? Why are they walking straight out into traffic? One of the women was hit by a car, and the two are causing serious disruption to the traffic. Eventually, some highway traffic officers arrive at the scene to assess the situation, and it only gets stranger from here. The two women are identical twins, Sabina and Ursula Eriksson. They're from Sweden. Sabina was the one who'd been hit by a car, but she sustained only minor injuries, and the two appear calm as they talk with traffic officers at the side of the road. Police arrive shortly after to assist, and they're accompanied by a TV crew who are filming some sort of cop show, so we actually have footage from this encounter. That'll save me a bit of work drawing, thankfully, but some of what happens next is a bit much to be shown on YouTube, so for that stuff I'll revert back to a more tasteful rendering of the event. The police first talk with the highway traffic officers to get an idea of the situation, but before they can get the girl's side of the story, Ursula Eriksson bolts and runs straight back out into the traffic. She is hit by a lorry travelling over 90 kilometers per hour, and her legs are crushed as the wheels roll over her. For my friends across the pond, that means she was hit by a truck travelling over 50 miles per hour, and her legs were suitably yee-hawed, partner. I'm talking start the GoFundMe page now, brother. Not wanting to miss out on the fun, Sabina also ran out onto the road and was sent over the hood, partner, of a colliding car. Both women are now lying motionless on the motorway as police scramble to stop traffic and get help for the girls, though they're pretty sure they're both dead. When paramedics arrive, they find Ursula is in a surprisingly alive condition, although she is immobilized. Despite this, she seems to be in some sort of frenzy and resists treatment, scratching and spitting at responders. I could never have the patience to do a job like that. Oh, I'm trying to help you and you want to fight? Okay. Sabina had been knocked unconscious after getting hit by the car, but she was starting to come around. It appeared she was similarly crazed and was shouting things like, "They're gonna steal your organs." Amazingly, she managed to get up. An officer trying to calm her down and keep her still receives a punch for her efforts, and Sabina runs off across the motorway again. Seemingly possessing super strength, Sabina is able to resist arrest. Even after some bystanders come to assist, it is a struggle to carry her by each limb. She is extremely agitated and is screaming for help, seemingly misreading the situation. She is restrained, sedated, and put into the back of an ambulance. Ursula is airlifted to hospital. Sabina was released from hospital only 5 hours later, her injuries being much less serious than her sister's. From here she is put into police custody and bizarrely is calm and collected, as if the violent outburst had never happened. It turned out Sabina lived in Ireland with her partner and 2 children, while Ursula lived in the US. Ursula had come to visit Sabina the previous day, but for some reason the two secretly left Ireland for England. Sabina had apparently had a fight with her partner the previous night and had gone to police to report concerns over the safety of her children. That day they had boarded a coach for London, but the bus driver became suspicious over their erratic behaviour and refusal to let anyone handle their bags. He let them off at a service station, telling them they weren't getting back on board and that they should just calm down and get the next bus. Instead, they apparently decided to continue their journey on foot, and shortly after that their strange behaviour was picked up on CCTV. A day later, Sabina pleaded guilty to trespass on the motorway and assault on an officer. The court sentenced her to 1 day in custody, which she had basically already served, so she was let go. Alright then, feels like maybe something more should have been done here. She wasn't even psychiatrically evaluated, they really just let her on. Yes, that's right, there's more crazy shit about to happen. Now back in the street, Sabina needed to find out what hospital Ursula was staying at. Around 7 p.m. that day, she bumped into a man walking his dog and his friend. Petting the dog, Sabina got talking to the man, 54-year-old Glenn Hollinshead, about her predicament and asked if he knew any nearby B&Bs. Feeling sorry for her, Hollinshead told her he had room at his place if she wanted to stay the night, and she agreed. The three went back to Glenn's house and chatted for a while. The 2 men noticed Sabina seemed almost paranoid, constantly peering out the window. At one point she offered them each a cigarette, but before they could light them she snatched them back, saying they could be poisoned. Her behaviour was questionable, but it was a bit late to rescind the offer now, and she'd be gone in the morning anyways. Glenn's friend eventually left the 2, and Sabina stayed the night. The next day, Glenn phoned up his brother who worked at a hospital to see if he could find out where Ursula was being treated. He makes food for himself and Sabina and heads over to his neighbour to ask for some tea bags. Only a minute after re-entering the house, Glenn Hollinshead runs back out. He has been stabbed 5 times with a kitchen knife. Reportedly, his last words were, "Look after my dog for me. Sir, go straight to heaven." Glenn's neighbour called the police as Sabina went on the run. She was later spotted by a driver who noticed she was hitting herself over the head with a hammer. Concerned for her safety, he left his car to calm her down, but she hit him in the back of the head with a roof tile and fled. What is happening? As police were making their way to the scene, Sabina made her way to a bridge overlooking the A50 highway and jumped over the barricade, plummeting 40 feet to the road below, breaking both her ankles and fracturing her skull. She survived, however, and was arrested on suspicion of murder. She was discharged from hospital and taken into police custody in September. Ursula was released around the same time, though she was never charged with any crime and she just fucked off back to the US. So, with Sabina on trial, you'd think we're about to learn what the fuck was going on throughout all these escapades, right? Well, listen to this, because it's crazy. Sabina offered no explanation for anything that happened and responded to every question with no comment. She pleaded guilty to manslaughter with diminished responsibility. Why diminished responsibility? Her defence counsel argued that Sabina Eriksson was suffering from folie à deux, or shared psychosis. They argued that her sister Ursula was suffering from a rare psychiatric disorder, and when they were together, Sabina sort of adopted this disorder, or was infected by it, due to the close bond between the twins, and together they convinced themselves of delusional thoughts. It was a temporary madness, meaning Sabina appeared sane in court, but was not so at the time of the crimes, according to her defence. She apparently had no criminal history before this incident. This was...
Okay, so folie à deux, it means shared delusion, okay? So folie is an irrational belief in French. À deux means 2 people, okay? So it's a delusion shared by 2. So this is pretty much the Erickson sisters is pretty much the key example for folie à deux. What questions do you have about that? Okay, so this is what an interview would look like with someone who is experiencing psychosis. So you can see the way the responding happens, that kind of thing.
Hi Andy, do you want to come on in and have a seat? I'm Dr. Taylor, I'm the on-call psychiatrist for this afternoon. I got a call this morning from your family doctor because I think you went to see him this morning along with your mum, and I gather that things have been a little bit difficult for you. You've had some rather distressing experiences. So I think your doctor thought it might be helpful for us to have a bit of a discussion about that to see if I could help. Would that be all right with you?
No, it's fine.
Would it be all right, Andy, for you to tell me a little bit about what's been going on?
Well, you're going to think it sounds stupid, but my housemates are working for MI5.
Right.
And they're doing stuff to my brain.
Okay.
And they're out to get me.
Okay, that must be very difficult for you.
Okay.
How long has this been going on for, Andy?
About 2 months.
Right. And how did you first work out that this is what was happening?
I came home one time and they'd moved the TV to the other side of the room,
Right.
and I knew then
And what was it that you knew at that moment?
that they were for MI5.
Right. Okay. Okay. So it's been going on a couple of months.
MI5 is kind of the
This new
equivalent of the
lecturer
CIA.
started at uni, and he works for MI5, and
Right.
he basically drafted my housemates in, turned them
Okay.
against me.
Okay. Okay. Now I've noticed a couple of times while we've been talking that you've sort of looked round you into the room as if you're checking for something. Could I ask you what's happening at those times?
Well, I can hear them talking about me.
Right. Who is it you can hear?
My housemates.
Right. So that you recognise it as their voices?
Yeah, I can hear them all the time.
Right. How many voices can you hear, Andy?
3. There's 3 of them.
Okay. And do they sound real, like my voice sounds talking to you now?
Yeah, it's odd. It's like I can hear them when they're not here.
Right.
And
so what they're not when they're not in the house with you?
yeah, it's like they're in the other room or something.
Okay. Okay. And can you hear what they're actually saying?
Yeah, they're talking about me.
Right. Okay.
They're always talking about me.
Okay.
They're always commenting on everything that I'm doing.
Right. Can you give me an example of what they would say?
Well, like if I'm packing my bag to go to uni or something, they'll comment on that, like he's left the house now. Or,
Okay. Okay.
you know.
Anything else? Do they ever talk to each other, perhaps about you?
Yeah, that's what they do. I mean, and now they know. They've sort of twigged that I know about them now,
Right.
and they're saying like I'm making trouble.
Okay.
And that they're gonna sort me out.
Okay. Okay. What about actually talking directly to you in the way that I'm talking to you now? Does that ever happen, Andy?
No.
Okay. So you've been hearing the voices of your housemates. Have there been any other changes? Have there been any changes perhaps to the way you're thinking? Sometimes people tell us that their thinking changes in some way. So for example, they might feel that they're getting thoughts put into their head that aren't their own. Have you had any experiences like that?
Yeah, I do think things that aren't me. Like they're putting stuff.
Okay, so what have you noticed from this video?
Is this guy like newly diagnosed?
Yes, that's the interview in which he is diagnosed. Did you
He can't
notice?
make direct
He's-
eye
he-
contact.
Okay, he's not making eye contact. Are you seeing any emotion on his face?
It's confused.
He is confused. What else?
He's very flat, like he's stating facts. This is what's going on. It's not like worry or anything.
Do you hear any emotion in his voice?
No.
Sounds
Not
to me
really,
like
maybe
he's
a little apprehensive.
okay, he's apprehensive. If I was afraid the CIA was after me, I might be apprehensive as well, yes. Okay, so with this, it's just him that believes this. So this is different than the shared delusion that we just saw. Okay, so it is one person, and he was diagnosed with psychosis. He wasn't diagnosed with schizophrenia, because how long do you have to have these signs for it to be diagnosed as schizophrenia?
6 months.
Yes, absolutely. Okay, so this is Memorable Psychiatry. Memorable Psychiatry, they have videos for everything. And I really like the way he outlines stuff. And as you're studying for the NCLEX and studying for finals, these videos are a great way to go through and do some reviews without having to go through and read the whole book and all that stuff. Okay, so we're going to watch that and be stopping it briefly throughout it for us to talk more about it.
Psychosis is an abnormal mental state where someone is unable
Can
to
you hear it?
distinguish what's real from what isn't. Using this definition, the word psychosis is an incredibly
Yes.
broad term that can encompass many possible symptoms and causes, including other conditions like delirium or dementia. In psychiatry, however, the word often has a more specific meaning, referring to a state of primary psychosis that is not attributable to any other medical or psychiatric condition. Someone in a state of primary psychosis still meets the definition of being unable to distinguish reality from unreality, but they do so in a very specific way that, once you learn it, will help you to recognize cases of schizophrenia when they occur. So for the rest of this lecture, we're going to leave behind the broad definition of psychosis and focus exclusively on the signs and symptoms of psychosis as they're seen in cases of schizophrenia. Symptoms in schizophrenia are classically split into two groups: positive symptoms and negative symptoms. Positive symptoms are those that are present in schizophrenia but absent for most people, whereas negative symptoms are those that are not present in schizophrenia but are for most people. Positive and negative symptoms make up the 5 diagnostic criteria for schizophrenia in the DSM. To better remember these, let's use the mnemonic HDBS network. This phrase stands for hallucinations, delusions, disorganized behavior, disorganized speech, and negative symptoms. The mental image conjured by this phrase should be easy to link to schizophrenia, as auditory hallucinations are common in this disorder. These voices are incredibly clear and sound like real voices of the patient, so they are very high definition. However, they're also not real, so it's as if the patient is hearing radio waves spreading a network of fake BS. Let's go over each of these one by one. First, the H is for hallucinations. Hallucinations are perceptions in the absence of a stimulus. While hallucinations can take many forms, including seeing things that aren't there, feeling things on your skin, or even smelling things, in schizophrenia the hallucinations are most often auditory in nature, reflecting the oddness of psychosis. More than just hearing voices, people with schizophrenia hear voices in a consistent and recognizable way. The voices typically take the form of a running commentary between several speakers, often a mix of male and female voices, who talk about the patient in a critical or demeaning way. The voices are intermittent rather than continuous, and are clearly perceived as coming from outside their head, as opposed to voices inside their head. These voices are not vague or nebulous. Instead, they hear what the voices say in a clear and vivid fashion. People with auditory hallucinations often experience them as distressing and will generally try to find specific reducing behaviors that can decrease the intensity of the voices, like listening to the radio, watching TV, or talking with others. Patients will also generally try to hide or minimize the fact that they experience auditory hallucinations. However, they may at times inadvertently reveal their experience by reacting to what the voices are telling them, which is described on a mental status exam as responding to internal stimuli. Auditory hallucinations almost never occur in the absence of other positive symptoms, with delusions being reported concurrently with auditory hallucinations nearly 90% of the time. And this leads us to the D of HDBS network, which stands for delusions. A delusion is defined as a fixed false belief. Fixed because they are unchangeable even when the patient is presented clear evidence to the contrary, and false because they are so clearly incorrect or incompatible with reality. Delusions must also be clearly outside the norms of one's cultural or religious background. So even if you find the beliefs of another culture or religious group to be strange, if they are shared by a large group, then they are not a delusion. Like auditory hallucinations, delusions in schizophrenia often come in specific and recognizable forms. In particular, schizophrenic delusions tend to be paranoid and persecutory in nature, such as someone believing that they are the target of a vast conspiracy. These delusions often involve ideas of reference where random or everyday events are connected in a way that has some great or cosmic significance. For example, someone watching the news on television may believe that the anchors are blinking in Morse code in order to communicate a special coded message that only they can understand. In addition to ideas of reference, delusions in schizophrenia also frequently involve belief that one's thoughts or actions are being manipulated by outside forces. These delusions include thought broadcasting, or the idea that one's thoughts are being transmitted externally to be heard by others, thought withdrawal, or the idea that one's thoughts are being taken out of their mind, thought insertion, or the idea that thoughts are being inserted into one's head by others, and delusions of control, or the idea that one's movements are not their own and that they're being controlled by someone else like a puppet. The final category of positive symptom is thought disorganization. People with schizophrenia often have profound difficulty with maintaining a clear and coherent train of thought. Because psychiatrists cannot read minds, thought disorganization must be inferred from disorganization in two other domains, behavior and speech, which make up the B and S of HDBS network. Speech tends to follow rules that are so ingrained that most people don't even realize them until they're broken. For example, during a conversation, most people go from one topic to another based on a linear train of thought involving logical associations between words and ideas. However, in a state of psychosis, the normal connections from one thought to the next are replaced by a loosening of associations, in which topics are connected by less meaningful connections. For example, someone in a psychotic state who is asked a question may answer based on the sound of words rather than their actual meanings, which is known as a clang association. If you were to ask a patient with schizophrenia, "What do you do at the beach?" they may reply by saying, "Beach, that's no leech preach, let me teach." In this case, the important part of the word, its meaning, is replaced by an irrelevant characteristic or its phonetic sound. Other ways in which thought disorganization can become apparent is when people simply make up words, known as neologisms, repeat what the other person said without regard to its meaning, known as echolalia, or say the same word repeatedly without any purpose, known as perseveration. In severe cases, thought disorganization can go so far that the words coming out of the mouth are complete nonsense, known as a word salad. In addition to speech, thought disorganization can manifest in disorganized behavior. Whereas most people behave in a way that is dictated by clear motivations, disorganized behavior in schizophrenia is notable for its purposelessness. People with schizophrenia may act bizarrely or unpredictably, such as walking around endlessly from one corner of the room to the next, repeating the same hand motions over and over, or copying a movement that someone else just did. Other patients may become hypoactive and simply stand in front of a wall for hours upon end. In some cases, patients may become agitated and prone to attacking others. While the behavior varies from one patient to the next, the key unifying feature is its purposelessness. Finally, the N in HDBS network stands for negative symptoms. While all the symptoms we talked about so far are positive symptoms, or things that are present that shouldn't be, these symptoms are things that should be present but are not. You can remember the main negative symptoms of schizophrenia by thinking of them as the 5 A's. The first A is for affect. While most people experience a full range of emotion, people with schizophrenia often have a blunted affect with very little emotional expression. Affective deficits tend to be progressive, and people with long-standing schizophrenia may develop a completely flat affect with no trace of emotion. The second A is for ambivalence. While most people are able to make dozens or even hundreds of decisions on a daily basis, people with schizophrenia often have extreme difficulty in making even simple decisions, which prevents most meaningful or goal-directed behavior. Even when asked about things that should be relatively uncontroversial, like if they want a blanket on a cold night, someone with schizophrenia may take several minutes to respond or not even respond at all. The third A is for alogia. While most people communicate frequently with others, patients with schizophrenia often struggle with speech, a state known as alogia. Alogia can range from small reductions in the amount of speech to being completely mute for months or years on end. The fourth A is for anhedonia. While most people have a range of activities that they enjoy, people with schizophrenia often experience anhedonia, or the ability to feel pleasure or engage in interests. Anhedonia can lead to a state of amotivation where people stop trying to pursue any form of goal-directed behavior, leading to an inability to hold a job or even take care of one's own basic needs like eating or bathing. Finally, the fifth A is for asociality. While most people enjoy socializing with others and consider this to be among the most meaningful parts of their lives, people with schizophrenia often develop severe difficulties relating to other people and instead are preoccupied with their own internal experiences. They often appear completely disinterested in what is going on around them, even during major life events that would normally provoke strong emotions, such as birth, death, and marriage. Many patients end up withdrawing socially and living in their own world, leading to isolation and loneliness. All right, let's take a moment to review our mnemonic, as we've covered a lot so far. You can use the phrase HDBS network to remember that schizophrenia involves hallucinations, typically auditory, delusions, often paranoid or persecutory, disorganized behavior, disorganized speech, and negative symptoms as captured in the 5 A's. Per DSM criteria, 2 or more of these symptoms must be present for a period of at least 6 months to qualify for the diagnosis. You can remember this by thinking of it as 2-4 schizophrenia. You need 2 symptoms for at least 6 months. So now that we know how to diagnose schizophrenia, let's take a look at the disorder across the lifespan, including who gets it, what happens once they get it, and what we can do to help. Schizophrenia is found in about 0.5 to 1% of the population, giving it a low base rate. It is typically diagnosed in early adulthood, with the age of onset being earlier in men, who tend to show symptoms between 18 and 25, than it is for women, who more often show symptoms between 25 and 35. For unclear reasons, men are affected more frequently than women, with 3 men diagnosed for every 2 women. Men also tend to have a more severe form of the disorder, with worse outcomes overall. While the symptoms of schizophrenia generally do not begin until early adulthood, many people who are diagnosed with schizophrenia show signs even in childhood, including odd beliefs, social withdrawal, physical clumsiness, and poor performance in school. This pre-syndromal state is known as a prodrome. Although these symptoms are common in people who go on to develop schizophrenia, they are unfortunately not specific enough to allow us to predict who will go on to have this disease, with only around 1/3 of patients diagnosed as having a prodrome actually going on to have a first break where active symptoms of psychosis emerge. As the other 2/3 do not develop schizophrenia, the risk of false positives from diagnosing and treating based only on prodromal symptoms is too high. For patients who do have a first break, schizophrenia often involves a lifelong pattern of acute symptomatic exacerbations on top of a progressive functional deterioration. This means that social and occupational functioning are often significantly impaired even when there are no active symptoms of psychosis. This is in stark contrast to mood disorders, where patients generally experience symptoms in episodes, with function often being preserved the rest of the time. Once a first break has occurred, the chance of future symptom recurrence is very high, with around 90% of people having another exacerbation in their lifetime. Consistent with the idea that schizophrenia is not an episodic disorder, psychotic symptoms do not have a built-in expiration date in the same way that manic or depressive episodes do. Studies have found that, without treatment, symptoms of psychosis can continue unabated for years at a time. People with schizophrenia often lead difficult lives. Less than 20% of people with schizophrenia are able to find employment, leaving them dependent upon others for support. People with schizophrenia are also more than 10 times as likely to be incarcerated or homeless than the average person. These patients also tend to live 10 or even 20 years less than their peers, likely due to the effects of homelessness, a lack of interest in medical care, and a higher chance of developing medical illnesses. Some of this gap in life expectancy may be attributed to suicide as well, with the diagnosis of schizophrenia being found in about 15% of all suicides. When suicide does occur, it tends to happen in an early stage of the illness, when someone's insight is preserved enough that they know that they're unwell and that they will likely not be able to live the life that they would have wanted. So in light of all this news about poor outcomes, what can we do to help? Treatment of schizophrenia generally consists of medications and psychotherapy. Like bipolar disorder, the standard of care almost always involves medications, as psychotherapy alone is not considered sufficient for treating schizophrenia in most cases. Medications used to treat schizophrenia are known as antipsychotics. Most antipsychotics work by blocking a neurotransmitter known as dopamine. With treatment, psychotic symptoms can be reduced in a matter of days or weeks. While antipsychotics are effective at rapidly reducing the positive symptoms of schizophrenia, like delusions and hallucinations, they are much less effective at treating negative symptoms. Because of this, antipsychotics are much better at improving symptomatic outcomes than functional ones. Hospitalization may be required for severe symptoms in schizophrenia. Many states allow for involuntary detainment of individuals who are gravely disabled to the extent that they are unable to provide for their own food, clothing, and shelter. Psychotherapy can be a very helpful add-on treatment for schizophrenia. A specific form of therapy known as CBT for psychosis has been developed to help patients take more control of their symptoms, such as teaching them to recognize when an idea is a delusion or when something they hear is a hallucination and not a real voice. And that's schizophrenia in a nutshell. Before we wrap up, let's talk about a few related disorders. We talked earlier about the fact that 2,4 schizophrenia cannot be diagnosed until a patient has had symptoms for 6 months. However, patients may still come to clinical attention for psychosis before that time frame, so what diagnosis can we give in those cases? Psychotic symptoms lasting less than a month can be diagnosed as brief psychotic disorder, while those lasting between 1 and 6 months can be diagnosed as schizophreniform disorder. The distinction between brief psychotic disorder, schizophreniform disorder, and schizophrenia appears to have prognostic value, as only a third of patients with brief psychotic disorder will progress to having full-blown schizophrenia, while only 2/3 of patients with schizophreniform disorder will do the same. So while the 6-month cutoff is ultimately arbitrary, it underscores the point that the duration of psychosis matters when it comes to prognosis, with a longer period predicting a worse outcome. Another related disorder is delusional disorder. This is a condition in which people develop delusions that are similar to those found in schizophrenia, but unlike in schizophrenia, all the other signs and symptoms like auditory hallucinations, disorganized thoughts, and negative symptoms are absent. In addition, the life course of people with delusional disorder does not mirror those of schizophrenia, as these people are often employed, married, and lacking in other features suggestive of mental disorder. On interview, they are often coherent, sensible, and reasonable until they begin talking about their particular delusions. If all the other parts of schizophrenia are missing, then why is delusional disorder a disorder at all? For people with this disorder, their belief in these delusions is firm enough that it can cause significant problems in their lives even in the absence of other symptoms. For example, if your spouse of 30 years suddenly started believing that they had been abducted by aliens working for the CIA and refused to stop talking about it, it may begin to strain the marriage, not to mention their ability to hold a job or maintain other friendships. Medication treatments for delusional disorder are not very effective, with very limited benefit from antipsychotics. Psychotherapy, like CBT, can help patients to lessen the social and occupational dysfunction resulting from these delusions by teaching them situations in which it is or is not appropriate to talk about them, even if the therapy doesn't necessarily remove the delusions themselves. And with that, we're going to bring this video to a close. If you're interested in learning more about schizophrenia, check out some of the other videos.
So tell me, is that video helpful?
Yes.
Yes.
Okay. So as you go on through the class, he has stuff for everything. So, because I know I've only got you guys for, I think, next week, and then we're kind of going from there. But you'll find his videos, all of them are free online, and they are very, very helpful with that. Why is the CIA so often involved? Good question. Often it is due to the CIA has done some questionable things in the past. With that said, they also are often given a level of power in people's minds that doesn't actually exist in reality. So, with that, a lot of times delusional disorders will involve the CIA. Okay. Is there any questions on what we've covered today?
Oh, it's just a lot of information.
It is. It is a lot of information. Just know that if you have a relative with schizophrenia, that it does not mean that you will develop schizophrenia, that there is a genetic component, but there's so much more to it. And really, we have more that we need to research with schizophrenia because we really don't understand 100% how it happens, what activates the genes, and we need more research within newer medications. A lot of the medications that we're using still today were actually created in the 1950s. So, with that, mental illness doesn't make a lot of money for pharmaceutical companies. So, as a result of that, there's very little new research that's been going on into mental illness.
So should we be concerned, Dr. Stanley, if we're talking to ourselves?
It depends on if you're answering yourselves.
I do that sometimes too.
Well, most of us very clearly do have a voice in our head. And so, with that, we are in a way talking to ourselves. The thing is, we know that that voice is not real, right? Where the problem is when you are hearing voices, conversations, and to you, you can't differentiate that it's real or it's not real. So that is where a lot of the problem comes to be. And yes, autism spectrum disorder would need to be ruled out to get to the diagnosis of schizophrenia. Now, with that, autism in the 80s, 90s, ADHD 2000s was the golden goose. And with that, there was an increase of diagnosis of ADHD, and we really weren't able to discern why there was an increase in diagnosis. Had it been there all along and we missed it. As for autism spectrum disorder, yes, there's so many differences between schizophrenia and autism spectrum disorders that you would have to differentiate. And in all honesty, a person could have both autism and schizophrenia as well. So you would need to be able to rule that out when you're looking at diagnosing schizophrenia. Okay, so which symptoms are easiest to get rid of in schizophrenia?
Positive.
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 Okay, so which symptoms are most disabling for a person in schizophrenia?
The negative, probably.
The negative. The negative ones are the ones that's going to be affecting their day-to-day life. Okay, so which type of antipsychotics have increased risk for EPS?
The dopamine?
They would affect dopamine, yes. Which type? Which class? First generation or second generation? Typical or atypical?
Typical.
Okay. Typical antipsychotics have more risk of developing EPS, EPS symptoms. So you need to know the difference in the EPS symptoms. There's a table in your book that outlines it. You'll need to know akathisia. You'll need to know torticollosis, which is where your neck muscles, the sternocleidomastoid spasms, and it causes them to not be able to move their head from it appearing to look backwards over their shoulder. You'll need to know dystonia. You'll need to know tardive dyskinesia. That's where the tongue and the facial twitches. And what's the difference in Parkinsonianism and Parkinson's disease?
Parkinsonianism is where it just mimics Parkinson's. We've medicated them to the point that they have those symptoms.
Correct. That we have blocked so much dopamine that it appears they have Parkinson's symptoms. Yes, very good. Okay, so since we have a few minutes extra today, I wanted to go back to last week, and we were talking about nonverbal communication. And this series is a fictionalized series, but the person that this is based off of is an actual leading psychologist who looks at nonverbal communication. And I think it's just very interesting because it pulls in pop culture pictures of different events that you can see what we're talking about with nonverbal communication. And so oftentimes we will say that we knew somebody was lying because they weren't making eye contact. They actually tend to make more eye contact when they're lying because they're having to look to see if you are buying their lies. Okay, so this goes into this is like the opening scene to the pilot of Lie to Me, and is introducing the different concepts of nonverbal communication. So you'll see him, the first scene, one of the first scenes is he is talking to a prisoner, and then it kind of evolves from there. But this usually sparks pretty good conversations.
I've instructed my client to remain silent. He's not going to talk.
Oh, it's okay. That's okay. I don't have much faith in words myself. Now, statistically speaking, average person tells 3 lies per 10 minutes conversation. And granted, it's just regular people. We haven't studied in people who are planning to firebomb a black church. Could skew differently.
We don't have time for this scientist to talk to the guy. We went at him for 4 hours and got nothing.
Now, the FBI knows you want mass casualties. So right now, ATF is searching every inch of the 2 largest black churches in the state. FBI got it wrong. Well, there's a shocker. Not one of those 2 churches. Maybe you want one of the smaller churches. One of the black suburbs.
You know what you're talking about.
Don't respond. What do you say ATF starts with Southbridge? No, I'm only kidding. We're gonna skip that one. They're gonna focus on Lawton. You feel good about it? That's it, Lawton. Going after a church in Lawton.
That accusation has no basis.
What do you mean? You just told me. The ATF found a pipe bomb in the church basement in Lawton an hour later.
DOD friend of mine said this guy's a total nut job. Heard he spent like 3 years in the African jungle with some primitive tribes studying their eyebrows.
What's his reaction to my statement? Right now, ATF is searching every inch of the 2 largest black churches in the state. Now, what you just saw there was a brief expression of happiness on his face, which he was trying his best to conceal. It lasted for less than 1/5 of a second as what we call a micro-expression. Now, look at his mouth. The suspect is secretly happy about the locations we are searching, which tells me we have the wrong locations. Now I tell him of our new plan, and...
You know what you're talking about.
Classic one-sided shrug. Translation, I have absolutely no confidence in what I just said. The body contradicts the words. He's lying. Yeah.
When you accuse a suspect and he acts surprised, is there a way to tell if it's real or if he's just trying to look innocent?
Now, that's real surprise. Lasts for less than a second when it comes across your face. But if your suspect is surprised for more than a second, he's faking it. He's lying. Now, I call out that this target is actually Lawton, and watch it again. Concealed scorn. One personal tip, you see this micro-expression in your spouse's face, your marriage is coming to an end. Trust me. Yeah.
Don't these micro-expressions vary depending on the person?
Let's leave this up and we'll go to the Cato Kalin footage. It's from the OJ trial.
Mr. Kalin, you got a lot of money for your appearance on Current Affair, didn't you?
Scorn. Scorn. Huge scorn. Shame, shame, and shame. Contempt. These expressions are universal. Emotion looks the same whether you're a suburban housewife or a suicide bomber. The truth is written on all our faces.
So what do you think about that?
That was a good series. I watched it.
It is a very good series. So
Dr.
micro expressions are a big facet within our behavior to be able to see what somebody's truly feeling. Go ahead. Somebody else was going to say something.
I was asking if you could read my mind if you studied these expressions that much.
If you are a very good student in that, yes. You'll also notice that when somebody takes a risk or discloses something personal, then they will often do some kind of self-comforting gesture. So women will often hold their neck, rub their neck, pet their neck, do something like that. Or if it's something that's really challenging for them to say, people will often cover their mouth. They will also do self-comforting things such as taking a drink as a way to help comfort themselves in situations in which they're uncomfortable. So this is going back to congruence and incongruent behavior. So if I am telling you that I'm open and I'm interested, but yet you see me like this, am I open and interested?
Well, you don't appear to be.
I don't appear to be, and it's really hard for me to maintain that scowl. Okay, so that would be incongruent. I'm saying with my mouth that I'm open and interested, but my behavior is incongruent with that. Okay, so congruent behavior would be saying I'm open and interested, having my arms out of the way, having my chest revealed. That would say that I'm open and interested. Another thing is, which direction are my feet pointing, as we talked about last week. So, what has anybody seen any examples of that they want to share? Okay.
Dr. Stanley, could
Yeah.
like if you're talking to someone that's not very self-confident and they're in a situation like that too. I mean, they could be trying to portray themselves as open, but at the same point, they're closed off because they're insecure about the environment that they're in.
And you're going to see that more with eye contact. And what will happen with somebody who's insecure is they won't make eye contact. They'll look anywhere around to avoid making eye contact. And you really won't see them closed off as much. You'll see them doing more self-comforting behaviors, whether that be rubbing something, like you'll see people doing self-comforting behaviors like taking their shirt and the fabric and then literally rubbing the fabric together on the shirt, or playing with their hair or playing with their neck, that kind of thing. Make sense?
Yes.
If someone's feet are pointed away or one foot is pointed away, they are wanting to get out of the conversation. Yes, absolutely. Getting ready to bolt. So also on your vocabulary sheet, there is a word that's misspelled. Anastasia, that was agnosia, right?
Yes.
Okay, so apparently there's so many words that Google thinks is misspelled anyway that I missed this one. It is agnosia instead of agnosia, I think is what the way it was spelled on there. And then there's also like therapeutic communication versus what not to say. And so therapeutic communication is good communication. What not to say, victim blaming stuff. It's your fault that you're in this situation. If you had only blah, 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 if you would listen to me, dictating behavior is a negative thing as well. So any other questions about the assignments?
I have a question about the AA assignment.
Yeah.
Is there anywhere online that we can find like free recordings of these meetings or
Yeah, there's
I
online
looked on
meetings.
YouTube and I couldn't find any.
You're not going to find them on YouTube. Go to the AA website online, Alcoholics Anonymous, and they'll have a search for meeting. There are online meetings that you literally can be snowbound and get that assignment kicked. Get it done.
Okay.
Okay, you're looking for an open meeting. The difference in an open meeting and a closed meeting is open meetings invite all community members, and then closed meetings are only for people who are struggling with alcohol. But you can do AA, you can do NA, which is Narcotics Anonymous. It's another 12-step program. And then you're just going to write about what worked well within the meeting, what didn't work well, how would you change the meeting up if you were running it, that kind of thing. What other questions? Good deal. Well, my plan is to see you in person next week, okay? If you need me, shoot me an email and let me know.